Yeah.
Okay. Thank you, Mr. Luizos. Mr. Thurman.
Thank you, Mr. Chair. You gave the 3 examples of other taxes structures that are in place: MCO, hospital, skilled nursing facilities. But did you say that there were 19
in total? Yeah.
Could you just give a few more examples of what exist? You don't have to go through the whole 19.
Yeah, I mean, I have
just the best ones.
I'm happy to forward you the list. I mean, you could do, services on immediate. I'm just going to read from the list, if you don't mind. And obviously, we're not endorsing any of this, but as an objective response, I just want to be clear, because I could walk into this audience and get hammered. No, but objectively, the list of permissible classes include like dental services, podiatry, chiropractic, optometric, psychological therapy, emergency ambulance services. I think some of these have already been considered in past, budget deliberations. Physician services, home health care, outpatient prescription drugs, and the list goes on. But yeah, there's they're located within the federal rules.
Thank you, and we understand you're not endorsing any. We want you to get out of the room today. So
yeah, exactly.
Thank you.
Yeah, thank you very much.
Other questions or comments? One quick question. I know you haven't arrived at any final version of a new MCO tax, but given the guidelines from CMS for what that MCO tax, the rules it must comply with, what do you anticipate with respect to impact on rates in the commercial space?
Yeah, I mean, we, obviously it depends on which path you take. We do have some numbers, like, for instance, the per member per month impacts of the governor's proposal. The premium, the hit to a commercial payer, and I'll define as a health plan for purposes of this discussion, can range anywhere from 75 cents per member per life or per member per month to $25.25 per member per month. So obviously, if we're a family of 5 in my house, so if our premiums went up $25 per person, that's $125 potentially in increased premiums, and you can extrapolate that out for the year. So, so that gives you an idea. I mean, the only other thing I'll say, Mr. Chair, is that these types of taxes and fees are reflected currently in the premiums. It's very difficult to absorb the entire cost of this within the plan, especially since one proposal actually doubles one of my plan's entire obligation to the state. They can't just write that off. So it's an affordability issue. I think when you look at aggregate costs, the $650 million that would result as a part of the January proposal is significant. I think there was an argument that was made yesterday in the Senate committee that this is really just 1%. This is really just a 1% tax across the board, and we would argue that 1% is a significant percentage. Facing, when you consider all of the cost pressures that are currently facing the healthcare system. So, yeah.
Okay. Mr. Thurman.
Thank you. What I'm curious about your work group and what the marching orders are in terms of what the objective would be. And the only reason I'm asking it that way, as you just stated, you have different plans are affected in different ways, and different vehicles, have a favorable impact or benefit, and others are deeply impacted by other vehicles. And so if there's not likelihood of coming up with something that makes everyone feel like they've won or not lost, I am curious about what the charge of the working group is and what is the ultimate outcome that this working group is trying to get to.
Yeah, no, thank you, Assemblyman, for that question. I mean, our operating principles are pretty simple. They're any MCO tax, the revenue generated has to go back into the MediCAL program, number one. It has to be equitable to the payers of the tax, and it needs to consider affordability to the purchasers. And so we didn't enter this project with any preconceived notion about whether the achievement of a new MCO tax was possible, impossible, or even inevitable. I think we didn't want to bog our process down early on with those existential questions, if you will. I mean, we really want to see what's possible. And we don't think that achieving those goals is impossible within the federal guidelines, as long as you're meeting the mathematical tests. But on the specific elements, affordability is a big one. Since people have to afford to buy our coverage. The goal there is really to minimize the impact on the commercial markets as much as possible. And then I think the employer community and the plans are going to have to determine whether any cost is worth the purported benefits of the tax.
And is there anything that your work group has gleaned from other states that would be useful for our consideration, who are also wrestling with the same issue?
Right. Yeah, there are many states that are wrestling with this issue. Just by way of example, we've been in touch with the Michigan Association of Health Plans and our counterparts in Pennsylvania. Those are two states that are wrestling with this question. Interestingly enough, their legislators are petitioning CMS to continue their existing MCO taxes. It'll be interesting to see how successful those efforts are. One state, Michigan, for example, tried an MCO tax based on claims data. They have a fundamentally different private market than we do in California. Ours is more capitated, where the plans pay a per member per month capitated rate to the medical groups that take on the risk. Risk is not allowed. Risk is only allowed for the health plans to carry, not the providers. So they're more of a fee-for-service claims-based market. So that works for them. Whether something like that could work in California, what we're doing is that we're eyeing the rest of the country to see if we can come up with more creative examples as well and catalog those.
Thank you.
Yep.
Thank you, Mr. Luisos. Appreciate your participation. Next, we'll go to public comment. I want to ask our members of the public to keep their comments to less than a minute. I'll let you know when you have 10 seconds left. Thank you.
Yes, my name is Mike Amolsch. I'm a MediCAL beneficiary. I live in California, Sacramento, California. I believe that the state of California needs to prioritize funding for the MediCAL program in special session. I have Parkinson's and a blood clotting disorder, which requires that I take warfarin, which is a blood thinner. My blood thinning level needs to be checked weekly, but my doctor can only see me once every 3 months. And she's tried to get me home testing, and that's been denied.
10 seconds left, sir.
There's a machine which has also been denied. I've been hospitalized 30 times over this because the warfarin levels in my system have gotten too high or too low, which has caused internal bleeding, strokes, and pulmonary embolisms.
Please wrap up, sir.
Okay. I ask you to please fully fund MediCAL so I can receive preventative care instead of just emergency room care. Thank you.
Thank you.
Good afternoon, members. Mr. Chairman and members, I'm Bill Barnaby. I'm here today on behalf of the California Medical Transportation Association and DaVita Dialysis. As I understand why we're here, it's because the governor didn't go along with the legislature's plan to repeal the 10% rate increase. Instead, he said, no, we're not going to do that. If you folks want to raise rates or do something, you have to pass a new MCO tax. So we support the MCO tax and hope it passes. But we've lost sight. We didn't hear anything from the administration about rates. That wasn't even mentioned. There's some plans to do all these wonderful things off in the future, but nobody's talking about restoring rates, and that's the basic underpinning. Now, it is correct that managed care organizations do care for more than perhaps 2/3 or 3/4 of MediCAL patients, but would it end that they're supposed to be paid on a
10 seconds left.
Actuarially sound basis? But does anybody understand that managed care bases their rates on MediCAL fee-for-service rates? If you don't raise MediCAL fee-for-service rates, you're not doing anything. Managed care has to be actuarially sound, but only if you know those payments go to the people who do the work, the providers. So with that, I'll leave and hope you do something positive. Urge your support of an MCO tax. Thank you.
Thank you.
Chairman Bonta, members of the committee, Eileen Ritchie with the Association of Regional Center Agencies. The majority of Californians with developmental disabilities rely upon MediCAL for routine and specialty medical care. Low MediCAL rates make access to medical care a challenge for those individuals. Areas of particular concern include access to specialists, dental services, durable medical equipment, and intermediate care facility services. Thank you so much.
Thank you.
Hi, David Thompson with the Dental Surgery Center Coalition, and I've heard it mentioned a few different times here that we have 1/3 of California covered under a MediCAL plan, but we should make a real clear distinction that they are only enrolled. They are certainly not covered. We see the cases all the time with the worst dental decay, and so we know they're not getting treated out there. We know that they don't have access to care for basic preventive dental measures. So we might have enrolled them within a plan, but they're not covered by any means. We do support the MCO tax because we need more money in the system because rates do need to go up. That's critical, as I've heard mentioned. Thank you for that. And we've heard the threat that possibly commercial rates could go up under this new structure of the MCO tax, but they're already going to go up. Last year, my private plan doubled. This year, it's going up another 20%, and that's way more than $25 per member. So if the only threat is that it's $25 per member, per plan, et cetera, it's already going up. That's not a threat at all. We should definitely pass this MCO tax and move on to additional revenue sources. We need more revenue. The MCO tax, that we're talking about money we already have. Please, MCO tax, pass it, and let's add additional revenue discussions. Thank you.
Thank you.
Hello, my name is Angelica Contreras. I am a MediCAL beneficiary out of Stockton, California. I believe that the state of California needs to prioritize fully funding MediCAL. May 6th of this year, I was at my temporary assignment and I was suffering a severe headache. I ended up leaving my job at my lunch period. I ultimately got hospitalized at Dameron Hospital after waiting in their waiting room for about 3 hours. That night I was diagnosed with aseptic meningitis, was hospitalized for 11 days, which led to me being terminated from my temporary assignment. I believe that if MediCAL was fully funded, this could be prevented, and I along with millions of other MediCAL members, would be able to get preventative care that they need from their primary care providers. Thank you for hearing my story today.
Thank you.
Good afternoon. My name is Samuel White. I'm also from Stockton, California. I'm also a beneficiary of MediCAL. I signed up for California MediCAL in November, but in order to see a doctor, I had to have a primary care doctor. It took over 5 months for me to get a primary care doctor. So I had to go, with my illness, I had to go to the emergency room to be seen. But had MediCAL took care of the physicians that would see us, they gave me a list of physicians to go to, but they was not taking care, they was not taking new MediCAL patients. And that hurts not only me, but millions of other people like me here in the state of California. So please, fully fund MediCAL, because we need the funding so the doctors can be taken care of, then they have to take better care of us. Thank you.
Thank you.
Hello, my name is Myrna Garcia, a medical beneficiary in Manteca, California. I believe the state of California needs to prioritize funding MediCAL in this special session because I had experienced a delay in care. I was suffering from sinus infection, called my clinic. They said I had to wait a month to go see my doctor. I couldn't wait a month. had to be rushed into emergency rooms. Not only do I stand here for myself, but I stand here for my daughter since I am a single mother, and I believe you should fully fund MediCAL.
Thank you.
Hello, everybody. My name is Monica Mayor-Quinn, and I'm a MediCAL beneficiary in Woodland, California. I'm here on behalf of my daughter because she is diagnosed with severe autism and mild mental retardation, which is really hard already for me to understand her. I have to kind of guess what she wants and, be around her all the time. Like a couple years ago, she started having something that the doctor described like seizures, so he sent her to have an EEG. It took me going back and forth to the doctor 1 year, 6 months, and 3 weeks to get her to the appointment because it was like a lot of issues in the middle. Just the fact to having a daughter with disabilities is really hard already, and just to wait all that, it makes all their family, become emotional, and without us struggles between us. Sorry, my English is not the best, but I try and I come in with my heart. Thank you for listening to my story today.
Thank you.
Good afternoon, Matt Robinson, California Association of Health Facilities. I'm here on behalf of our intermediate care facilities for developmentally disabled. Now, these homes are 6-bed homes. It's a community setting. They are one of the 19 provider groups who do pay a provider tax. They've been doing so since 2003. They're 100% MediCAL funded. These guys have taken an enormous hit. They're under a 2008-2009 rate freeze. They've also sustained AB 97 rate cuts, and they're also capped at the 65th percentile for their cost reports. There's been over 66 closures of these facilities since 2012. And in your subcommittee, Assemblymember Bonta and Thurman, you asked the question. They are the most cost-effective option for this community for developmental disabilities and intellectual disabilities. So thanks.
Thank you.
Thanks, Chair and members. Kathy Mossberg, representing the Developmental Services Network. In the interest of time, I'll associate most of my comments with those of my colleague, Matt Robinson, with CAF. Want to just sort of further, we are one of those, talk about the tax piece, we are one of those groups that tax themselves early on. That tax plus a match that we do with our day programs and transportation brings in about $70 million, but yet we're still under a rate freeze. We hope that whatever this group comes up with as it gets to a solution on this, you do work to, as MediCAL, as you work towards a MediCAL solution, get at that issue of the rate freeze for these facilities. Thank you.
Thank you.
Hello, my name is Fabumi Sands. I'm an emergency room for Kaiser Morris Emergency Room, as well as an SEIU UHW member. I'm here to explain to you how hard it is for us. We are now at ground zero. People say, oh, we've done significant things, significant changes with MediCAL. No, you haven't. I'm sorry to tell you that. I'm seeing it firsthand. I'm seeing patients come in who can't, because they can't see their primary care physician, they use us as the lab technicians to draw their bloods. They use us for their dialysis because they can't figure out a way to get down the mountains from different cities to come. So therefore, we have to take care of them, do dialysis on these patients. What pulls from a patient who's coming in as a code 3? A code 3 is a patient which is CPR in progress. We're doing what we can to save that patient. But the sad thing about that is because we're so inundated and impacted by so many Medicare patients as well as psych patients, we can't even find a room to actually sustain to help save that patient's life. I recently was at work yesterday and watched a kid who I had to help induce and go ahead and put his bone back in place. But because he didn't have the proper Medicare, that this patient basically, we gave him a splint and sent him home without a cast. The thing is that patient would actually need to follow up, but we couldn't do that because that patient couldn't find a proper primary care physician who get him in to see an ortho tech or an ortho physician to actually set the bone properly and put it in a cast. So I'm just here to give you just a few quick synapses on what's happening in the emergency room. And like I said, I'm an emergency medical technician. My job is to save lives. My job is to help put people back together and put them on, send them on their way. My job is not to figure out how to make money, but I know with the MediCAL fundings, we do need that project to be fixed, so that way we won't be overworked. Our physicians won't be overworked and dogged out. We're working to 17 to 18 hours.
Please wrap up your overtime.
Thank you for your time. Please fix the funding bill.
Thank you.
Good afternoon. My name is Georgette Bradford. I'm an ultrasound tech with Kaiser Permanente here in Sacramento, and also a member of SEIU UHW. Prior to the implementation of the ACA, many a time I've had patients on my table who have told me I haven't had coverage, I haven't been able to have a mammogram, as we specialize in breast imaging, and we're having women that should have been seen years ago have advanced breast cancer because they didn't have anyone to go to for primary care to get mammograms. Now we have the ACA implemented, but it's still not full coverage for those people that have been able to sign up who are on MediCAL because they can't find a primary care doctor to get coverage. So we still have women that can't get care for lumps that they feel to come in for years or months because they can't find a primary care person to see them, or there is no provider in their area because no one wants to take MediCAL. And these are women that deserve to have that care. These are mothers, sisters, and daughters. And it's just a shame in this state that somebody cannot get care, preventative care, and end up with a fatal disease just because they can't get primary care in the state of California. Please, please fix the funding of MediCAL. Thank you.
Thank you.
Good afternoon. Braden Oporowski on behalf of CASA, California Association for Health Services at Home. We support increasing MediCAL provider rates for reasons already stated. One thing I did want to share, I delivered a letter to your offices yesterday that showed studies by AARP and CMS about the cost savings for home health and home care services. And so as we look at ways that we can try to raise money to provide MediCAL services, it's also good to look at different effective and efficient ways that we can provide services. So thank you very much.
Thank you very much. Seeing no further members of the public making public comment, any members would like to make closing remarks? Just want to express my appreciation to the committee for your engagement, and I want to thank again all of our panelists, all the witnesses who served on the panels today for your insight and expertise and contributions to today's discussion, and most of all, I want to thank the members of the public for your engagement, your presence, and your heartfelt comments today. There's much to be done, as we've discussed, and very little time to do it. So, again, I appreciate all of your engagement. We've all been diligently working together. I've been working on legislation, as have other members of the legislature and advocates and stakeholders, and we've been working together with experts like those on our panels today, as well as on the panels from our other hearings, and we'll continue to solicit input to help inform the most creative, most effective solutions. And just want to encourage your continued involvement and let you know how much we welcome new ideas and input and feedback. The Senate, as you may have been tracking, has taken action on some of the special session bills, and this committee is tentatively planning to hold a hearing on Tuesday, August 25th, and more information to follow on the exact agenda of that meeting and what we'll be taking up. As always, I want to thank my fellow committee members for your engagement and your insightful contributions in both today's hearing as well as our prior hearings. I look forward to our continued work together. Thank you very much. This hearing is adjourned.